Good morning, everyone. Ooh, come on. Good morning. It's not that early. Come on. So it's good to be here. Renata, thank you very much for the invitation to be here. I wasn't here yesterday, so I don't know. Did Renata get recognized for pulling this all together? She did? Some are saying yes, some are saying no. Well, let's do it again. So let's just thank Renata for pulling this all together. So Renata has told me that she, in working in partnership with others, is bound and determined to drive down the tobacco rates in Region 3 and to make a very concerted effort to focus on behavioral health in doing that, because we all know the disproportionate number of people with behavioral health disorders, of course, who use tobacco. For those of you who don't know Renata, when she sets her mind to something, it is going to happen. So if you have an opportunity to join with her, I would certainly encourage you to do that, because you'll be part of a team that's going to make a difference. So I'm going to start with three very brief disclosures. One is I'm a big believer in integration and whole person wellness. I actually grew up in a household. My father was the director of a YMCA, and which is kind of this triangle, which is the mind, body, and spirit. So I have that kind of in my bones, that if you neglect any one piece of that triangle, then you're not reaching your full potential as an individual. And I know that that has influenced me throughout my entire life, and it's made a big difference for me. The other disclosure is that for a big chunk of my professional life, I provided home-based family therapy in the housing developments in the Boston metro area, Cambridge, Somerville, and all those areas. So I was in people's homes several hours a day providing family therapy, focused primarily on kids that had either been removed from their homes and we were trying to reintegrate back into their homes, or kids who were at significant risk of being removed from their homes and we were trying to keep them there. We were kind of the last desperate effort to keep families together. So I have seen it all. Child prostitution, gangs, violence, a lot of drug use. And I've heard, much like many people who work in addiction, have heard every story imaginable, right? We've heard it all. And we know the struggles with that addiction, but not much attention on tobacco at all. Certainly, clinical psychologist, I had zero training on that. I don't think it was even ever mentioned in my training. And the whole physical health component was completely neglected as well. So the third component is that even though I had this father who was the director of the YMCA and very focused on whole body wellness, my mom was a smoker since she was 17. And the other piece of that was she's a nurse. So a nurse, not just a nurse, but a nurse who treated cancer patients. And so I was one of those kids who grew up in the car where they would crack the window to be considerate of all the kids in the car, you know, so the smoke would kind of go out the windows, which of course it didn't really do. It was kind of like smoking on the back of the plane. It didn't really do much good, but it was a move in the right direction. And so I saw the power of that addiction. Here my mom was treating cancer patients every single day, and she could not kick the habit of tobacco use, even after seeing the ill effects of that. So that was a very important message to me, too, about the power of this particular addiction. So I think that we are well positioned and poised to make a big difference, a really big difference. There is an Institute of Medicine report. If you have a chance, just Google Institute of Medicine, integration, really talking about this integration between primary care and public health. Great report. I don't know, maybe you have this in your slides, but there's a continuum that starts at the kind of the position where most of us start, which is around collaboration, around partnerships. You can think about this in some of your FQHCs where services are co-located, or it might be where you're making a referral down the street, or you simply have those kind of cooperative agreements, all the way over to a real merger, where everything is really integrated and offered together. And very few actually make it to that level of integration. And it's on a continuum. So you can kind of find out where you are on that. It's a very helpful resource. But this is really a hot topic in public health. And it's, I think, a significant time in our history because we are seeing the landscape change right before our very eyes. So we have this #1 killer, tobacco, the #1 cause of preventable death certainly in the state of Oklahoma, as it is in pretty much every state and certainly in the country. The #1 killer, and it's preventable, and we really have neglected that as a field. You know, we get into this kind of body part mentality where we treat different parts of the body, and currently we have entire agencies set up. So we have some great representatives from the Oklahoma Department of Mental Health and Substance Abuse Services here, so you raise your hands. So if you have any questions from anything I say, there's the answer right over there. But that is the only department in our state that is set up for a specific disease. So we don't have a department of heart disease or a department of cancer. We don't have any other department that is segregated and sometimes marginalized. And I understand the history and the evolution of that. It's absolutely necessary in the early days. And Renata, you don't go back quite this far, but I'm sure you've read about it, right? Where the field was so neglected and so overlooked, it really needed its own position in the world to survive. It did, because it was always on the second or third rung. Well, I will tell you, I think that addiction, substance use, abuse, and mental health have come of age. And I believe that they can stand on their own within integrated systems because they are strong enough to do that now. Historically, they weren't. So I'm not critical of that separation at all. I think it was necessary to have that fundamental split. Otherwise, it would have been lost, at least the way that we're structured here in the United States. So as these other fields move to this integration, I think that the behavioral health field really has a lot to offer and teach. As Chad was saying, this idea of medical homes, it's a hot topic in physical health now. Medical homes. Guess what? Behavioral health's been doing a lot of that medical home model for years, whether it's on the addiction side or on the mental health side with PAC teams and others. We have a lot to teach the rest of the world, and we need to make sure that we're front and center in doing that. Now, does that mean that we do that perfectly? Does that mean that we do that necessarily well in all places? It doesn't. But we certainly have that expertise. And as Chad said, there's a lot of evidence, we have a lot of information, but we don't always practice what we know. And that's the challenge for us then, is moving that evidence base into an actual practice base and implementing it in a way that's meaningful. So in Oklahoma, just as an example of some of the critical partnerships that we have in place, we are very fortunate in our state to have Tobacco Settlement Endowment Trust, which we just call TSET for short, Tobacco Settlement Endowment Trust. The fortunate way that was constructed is actually constitutionally protected. So there's a separate board that actually dictates how those monies will be appropriated. It is required to go back into health-related areas, and it can't be touched by the legislature, which is very important, especially this last week of the legislature, as we're seeing significant cuts to state agencies. We know in many states that have been front leaders, those funds have been completely eliminated during the recession and the budget shortfall years. And strong tobacco cessation programs have been completely defunded, which I think borders on criminality when we know these programs save lives. So how could you actually cut money from these programs to build roads and infrastructure, all of which are important, but we're talking about lives saved. So TSET in Oklahoma has seen its fund grow every single year. They have become a larger and larger player. They cannot spend the corpus of that. They can only spend the interest on the investment, so it will only grow over time and cannot be depleted, and it's reached a critical mass. So one of the things that they've done is to fund many of the services through the Oklahoma Department of Mental Health and Substance Abuse Services. And they are absolutely on board with tobacco cessation. So looking at this kind of public health model, and I'll tell you, as a former SAMHSA administrator, one of my frustrations was our kind of piecemeal approach. So we're doing fantastic work, making a difference in people's lives, but it's one person at a time and one family at a time. And we're not going to get there. We're not going to get where we need to be unless we apply that public health model, really step back, look at the population as a whole, look at prevention efforts. Again, this is where addiction and substance abuse understands the importance of prevention, as does public health. Being able to use data to make decisions, again, not being driven by the anecdotal story that's before us or the most pressing issue of the day, sometimes chasing one drug intervention after the other, which we do, whatever the hot drug may be in the moment, without really stepping back and looking at what can we do to really promote wellness in our communities. If we do that well, then we are taking in all of these drugs, and we're really looking at those risk and protective factors that many of us were raised on in terms of that concept. So in Oklahoma, part of that funding has been to really develop data systems. The Department of Mental Health and Substance Abuse Services has included tobacco use in its client data core, which is very important. You don't know the magnitude of the problem if you don't have good data to really understand that. And so the department has done a great job of doing that. Also has developed a customer survey specifically targeted with information around tobacco use. So this is looking at the kind of public health model. You have data, you're looking at screening, you're looking at training, you're looking at interventions, and then using data to modify that over time. Kind of that rapid cycle improvement and quality improvement. And that's what we've seen for the Department of Mental Health and Substance Abuse Services. So they have included in all of their contracts with all of the providers, the majority of providers in the state are actually private contractors, the requirement to provide tobacco cessation. So that started going back several years by banning the use of tobacco products for the facilities provided by the state, and then extending that to those contractors. And that was a big deal. I don't know, how many of you work in states where that's banned for all of your providers, tobacco use on those properties? Do we have any? So we have some, certainly not the majority. It's a big deal. And I remember when that took place. And so you have some long-term care facilities when you have mental health and behavioral health and addictions all together. And the biggest challenge, frankly, was not with the clients or consumers. It was with the darn staff, right, who are sneaking around the corner to have a cigarette. It's absolutely true. And we had a really, really high rate of tobacco use for our staff. And then when we had those bans, it gets a little more complicated. Then you would have staff who would go off on their break, who would come back reeking of tobacco, right? So you've just told everyone in the program that you can't use drugs in the program, and you have someone who comes back reeking of tobacco. Now, if somebody came back reeking of marijuana, what would their response be? Or if you knew that they were using some other drug that was prohibited there, what would the response be from that particular facility? But we've had a real double standard with tobacco. We have. And I have a little bit of a bias here, Renata. I'll try not to get anybody in trouble. But the tobacco industry has been so successful at integrating this into our society that we have these sets of rules that are different for tobacco, even though it's the #1 killer. So the Department of Mental Health and Substance Abuse Services banned that use, did these surveys to collect data, actually trained staff and required training around motivational interviewing, the use of pharmacological interventions with clients to make sure that it wasn't just one facility, but actually all of the providers who had the ability then to provide this life-saving intervention. Screenings being done, the referrals to the quit line. I was talking to Ivan earlier. This concept that I'm still struggling with a little bit because I have a hard time. Anything that's over 100%, like 116% or 120%, I'm like, how's it over 100%? But he had to explain it to me this morning. So they've had over a 600% increase in the number of referrals to the quit line for clients there. So the first year, about 150 referrals to the quit line, and now they're exceeding 1,000 easily every year, and that number is growing. So working with the quit line, actually that's one of the questions that the quit line now asks about your potential struggles with either addiction or mental illness, very specific services that are tailored for this particular population because we know the intervention should vary slightly for that. And it has been very successful. So one of the quit line questions is, have you used cigarettes, even a puff, in the last 30 days? And doing that 7 months out from use of the quit line. And the success rate for behavioral health clients is at 32.8% who answer that they are not using any tobacco product. That's pretty impressive. And that's a great success rate for any quit line, but then you couple that with behavioral health, it's even more impressive. So the department also believes it's important to model and to practice what we preach. And I'm just going to close with this. They have set up providers of excellence programs, wellness providers of excellence, which really then take this a step further. So again, making sure that we don't fall into the same trap. So now we're going to add tobacco, and meanwhile, our families will be dying from obesity-related illnesses, diabetes, other things. So again, this focus on wellness. What can we really do to make sure that we're focused on overall health and not just taking one disease category at a time or one challenge at a time? So part of this Providers of Excellence really talks about nutrition, physical activity, in addition to tobacco, to make sure that we're a little bit broader than that, and that we're, you set up a matrix and you really understand what types of activities are available to the individuals and families that you are working with, and what we're doing to move the needle for those particular populations. So I am a big fan, obviously, of the Department of Mental Health and Substance Abuse Services, the people at this table, as well as their commissioner, Terry White. Has just done a fabulous job of taking this on and understanding the importance of tobacco cessation. All of us have heard the story, somebody who's made it and has survived. They're in recovery from their addictions, and they die at 52 from tobacco-related illness. And it's happened right before our very eyes, and we've just neglected it. So this is the opportunity, I think, that we have. So I leave you with the question, what can we do to move whole systems? What can we do to actually improve the health of an entire population of people? And that's where that public health kind of approach and philosophy comes into play. Are we moving the needle? Are we reaching enough people to impact that critical mass so that we can see those numbers go down? Again, fantastic for each individual, but it's not okay to serve this table of individuals and to know that they're going to have an improved quality of life and to sacrifice the other 15 tables in this room. That's not right. There are too many losers in that game. So we need to make sure that we're invested in reaching the entire population of people that we can impact. So just to close out with a nice quote from David Satcher, who was in Oklahoma last week, speaking at the Public Health Annual Conference there as the 16th Surgeon General of the United States, who issued the first mental health report in the country as Surgeon General. And his quote, which is one of my favorites, he said, the difference between knowing and doing can be fatal. We know a lot. We have a lot of evidence, but we don't act on it. We don't move it into play. And when we don't do that, people's lives are in the balance and lives will be lost. So I would put that challenge out there. How can you take what you've learned here over the last couple of days? How can you contribute to the knowledge base so others can learn from the outstanding work that you are doing? What can we do to move that into action so that we can impact all those other tables and improve the health of our population? So with that, I'll close and say thank you.